2, 1. We are live now.
Fine. Good evening, everybody. We've got back to our webinar today after a gap of 1 week because of the Indian Orthopaedic Association meeting. And today we have the pleasure of having Professor Pal from Kolkata. He's going to teach us or talk to us about a very important part of the clinical examination, and he's going to look at how even with very simple cases, you can make mistakes and get into trouble. So how do you avoid that, and what is the best way of dealing with these cases, and how you present them, and what are the questions you would expect in them? So I think this should be really very useful for all the DNB candidates as well as the postgraduate candidates. So thank you very much, Dr. Pal, and over to you.
Okay. Good evening to all. Thank you, Dr. John Mukhopadhaya, for his endless, continuous endeavor to improve the knowledge and skills among our postgraduates. So I salute for that. And with the continuation of this, just I'm here to discuss about the common mistakes. The common mistakes what we are doing in our examination. Even once we are in the students, we are also doing this same type of problems and mistakes in our examination. So that should be corrected. Everybody knows the subject, but the way of presentation is extremely important. So without wasting up time, I'll start with the elbow examination, which is the most important topic. Because the most important cases also it is given in the examination. So as you can see here, the orthopedic is, all of you know, it has a 7 broad heading: inspection, palpation, movement, measurement, special test, joint proximal, joint distal, and then lastly, there is a neurovascular reticuloendothelial system, that is a lymph node examination. So first of all, see the inspections. What should be the ideal ways of inspection? See, there are 3 cases I have put in. So on the left side, see, this is this one. All of you know, this is the cubitus valgus deformity. The middle, you can see here, is the cubitus varus deformity. On this side, can you tell what is the deformity? What is the normal? Which is the normal side? Which is the abnormal side? So basically, so this is not the way of examination. So what is the actual way of examination? Actually, see, made a video.
So elbow examination, we started from the standing position. Patient should stand in supine, then standing in anatomical position. That is in looking straight. Elbow should be side of the body, and in this manner, all the legs should be parallel, and the foot is planting. So this is the alignment. We have to examine from this side, from the lateral side, and also from the lateral side. See, this is the parallel group, and close. This is the parallel group. So these are the muscle bulb, this is the muscle bulb, and also this is the parallel group and the.
So they have to examine in the anatomical position. So once there is a cubitus valgus or cubitus varus, next question will be what are the points in favor of your diagnosis. So you have the student starts, everybody starts with there is a history, but this the most important point is why it is cubitus varus or cubitus valgus. Once the patient stands in anatomical position, then see, this the patient stands in anatomical position, then there is a division of the forearm towards the body, towards the center of the body, in respect to the arm, when inspection from the front as also from the side. This is the complete answer. See, this is the case. This is the, see on this side, this is the, it may be the normal side. This is actually the abnormal side. There's some history of trauma. So the history only detects, it only suggests to identify the site. But this is the case where you can see here the forearm is almost in the same line with the arm. Basically, it is a case of cubitus rectus. So the history only suggests the site. Otherwise, this is the way of examination by inspection. Okay. Now the deformity should be examined not only from the front, from the side, also from the back. Suppose in this case, say this is the deformity. If this deformity is examined from the front, that may be missing. So you have to always examine from the side also. This is basically is a claw hand deformity. You see, this is the cubitus valgus deformity with claw ulnar clawing, and that is the consequence of the non-union lateral condyle with cubitus valgus. Now see, where you have to examine the swelling and the wasting. always swelling should be examined on all the deeper, all the limbs has some high areas and the low areas. All of you know the fluid always collect in the low areas. So how to identify what are the low areas around our limb? See on the limb, see this is the cubital fossa in front. On the back, I've already shown there's a para-olecranon groove. These groups should be examined for this swelling. See if there's any collection, say any liquid or any collection of the fluid or diffusion of the pus of the blood, that low areas will be filled up, and that is to be compared on the other side. Now, wasting. What are the areas to be examined for the wasting? Basically, wasting occurs on the muscle bulk. So we have to identify the areas where the maximum muscle bulk. As you can see here, so this is not the actual way. You have to a little bit make it bare. See, this is all of you know, this is the left side is the abnormal side, but we have to examine the middle of the arm. And you can see here the shirt is little bit tight here, whereas the shirt is little bit loose. That means you have to open this area to check the muscle bulk of the biceps. Similarly, the triceps also have to examine from the back. Again, in front, in the forearm, you can see the forearm, the maximum muscle bulk is the upper third of the forearm. So we have to check the upper third. Here there is a swelling. So it is that there may be wasting, maybe must by the swelling. But still you can see here, if you measure these areas, you compare these areas with these, there is a significant swelling, significant wasting is there. Again, in the hand, where are the areas to be examined for the wasting? In the hand, you have to examine for the thinner eminences. You can see here, see definitely there is a wasting on this side, and also the hypothenor eminence in the palmar aspect. And the dorsal aspect, you have to see the intermetacarpal areas. Normally, the intermetacarpal areas are filled up. There is common filled up. But if it is a wasted, there is some convex, there is concavity. So these areas to be examined for the wasting. Now, swelling. See on this side, can you suspect any swelling over here? Definitely yes. If you compare both the side, that is how you have to examine. This is the way. Otherwise, this swelling can be easily missed. There is a swelling in front of the elbow joint. So you have to keep both the limbs in a symmetrical position. Otherwise, you cannot identify it. Basically, what is it? If you palpate it, then only you can tell this is basically the dislocated radial head. Now, the examination from the side. You have to side only you can identify the anteroposterior diameter. As you can see here, the anteroposterior diameter. If you see from the front, that may be missed. If you see from the side, then only you can examine the anteroposterior diameter of the elbow, as also from the other parts of the limb. So, what is the exact?
Suppose this is the
how to examine the temperature?
Can you see? This is the normal side, this is the abnormal side, and this is the normal side. This is the temperature. Now, the tenderness, for the tenderness, you have to palpate the bony points. So, have you identified the bony points? The lateral condyle. The lateral condyle is started from this. You have to flex it, you have to make it a little bit relaxed, so that the border is running on this. So, our rule of palpation is to palpate at its right angle with the help of the three pulp, like this. Three pulp. This is the lateral supracondylar ridge, and the bony points, which is downmost and outermost bony points along the lateral supracondylar ridge. This is the lateral and supracondylar ridge.
Yes, it's the downmost and outermost bony point. You have to mention it.
You have to palpate this is the medial supracondylar ridge, the downmost and innermost bony point along the medial supracondylar ridge. Is the downmost and innermost bony point. So,
and the most important, how to identify the supracondylar ridge. The rule of identification of those any longitudinal ridge is we have to palpate at its right angle. So you have to, if you use the pulp, three pulp, and if you move the three pulp at its right angle to the direction of the ridge. Suppose if you shin, you have to in shin also. If you want to palpate the shin of the leg, you have to give all the three pulp at the right angle to the direction of the shin. It is very easy to identify. So this is the rule of palpation of any ridge. And for the medial and lateral condyle, if you palpate along the medial and lateral supracondylar ridge, this is the downmost and outermost bony point. Along the lateral supracondylar ridge is the lateral condyle, whereas the downmost and innermost bony point along the medial supracondylar is the medial condyle. Okay.
this is the medial supracondylar ridge.
And this is very important.
Like this. See, this is the.
So this is very important. This is very important for the comparison of the three bony points. Okay. Now, how to identify the olecranon? You can see.
Okay. The olecranon, you have to see the palpate, the right
Yes,
angle,
see?
the
The same
bottom
thing.
of the
Same thing. Yes, that is, we have to graze all of the 3 fingers along the right angle to the direction of the reach, so that you can easily palpate. Okay. So always the rule of palpation of any reach is always palpate at its right angle. So we have to take the help of the 3 pulp. We have to graze the 3 pulp at the right angle to the direction of the reach, and you can easily identify. So even in a very hefty patient also, you can easily identify the reach. And once the reach is identified, then next step is we have to identify what is the irregularity of the reach, whether it is a thickening of the reach. So it is very important for the diagnosis of the supracondylar fracture. So they have to palpate the thickening of the reach, lateral supracondylar reach, as also the medial supracondylar reach. We have to compare this on the both the side. Okay. So this is the way. And if you go directly downwards, the downmost point along the lateral supracondylar ridge is the lateral condyle. The downmost there's a downmost point on the medial supracondylar ridge is the medial condyle. Okay. Okay. Just I'm restarting as it is.
Okay, sir.
Yes, just I'm restarting.
Okay.
Yes. Yes. Okay. Just a minute.
Yeah.
Is it no? It is a board. It is.
It's the screen is shared, but it's not the
Okay.
presentation.
Okay. Okay. Just a minute. Why it is not coming? Okay. Okay. Elbow deformity. Yes.
Yeah, you'll have to.
Is it? Has it come?
Not yet opened, but your screen is there.
Is it come? Is it visible?
No, it's not yet opened. You
It is
need to
not.
open the presentation.
Okay. Just a minute.
Is it open on your screen?
Yes. 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 It is open.
Yeah, now it's come. Yeah.
Okay. Okay. So this is the way we have to identify the medial lateral supracondylar ridge. Now inspection from the back, as you can see here, is back examination is also important. As you can see here, the whole of the parallel groups are completely obliterated, as you can see here. And this is the most important test I can show you.
Now the temperature. Suppose this is the disease tempo, the almost bony point. See? Similar thing you have to do with
Yes.
You have to palpate like this. See, this is the medial epicondyle, this is lateral epicondyle, this is the.
Now this is the most important test. I'm just going to show it. Just just I want to go show it. See, this is the position. Once you have palpated all the 3 bony points, then there's a relationship of the 3 bony points is examined. And this is the way by which this is the way. Another way is to put both the hands by the waist and to check from the back. So either you have to put both the hands on the head and you have to check all the 3 bony points from the front. This is one way. Another way is we have to ask the patient to put both the hands on the waist, and we have to check the relationship of the 3 bony points from the back. So this is in front. If you see from the front, as you can see, this is the case. So you have to see, this is the olecranon, this is the lateral and the medial epicondyle. We have just make it. It is a simulated like this. So if it's this, both the elbows are kept by side. If we make a imaginary line, that line joining the 2 olecranon, tip of the olecranon, and both the interepicondyle line, both the lines should be parallel to each other. But if there's a medial tilt, I will show you. If there's a medial tilt, suppose on the left side is a medial tilt, so there's the tip of the medial epicondyle would be going higher up in relation to the medial epicondyle. That is actually diagnosed. That is described by Shyam, and it is sometimes it is mentioned by Shyam test. That is the relationship of the 2 bony points. It is compared side by side. That is basically the medial epicondyle. And what I added, that is actually these both the lines, imaginary lines joining the 2 olecranon and the 2 trans epicondyle line. This should be ideally parallel to each other, but that is broken, and then on the affected side, it is converging to each other. That is the most important thing. Okay. Okay. Actually, the videos are running now. That is the problem. Just again have to stop it and again.
Okay, sir.
Okay. Has it come?
Yes, sir.
Yes. Okay.
Yeah, now I think.
Okay.
Not just.
Okay, just a minute. It will come.
If anyone have any doubts in between, we can take.
Yes, in the meantime, we can take the questions.
Yeah, that's true, sir. So sometimes about these 3 bony points, it's not actually when there is like some in the fracture case or in non-union case.
Yes.
Is it having some fallacy, sir, or it's always okay to have?
No, it is always there is no fallacy at all. We have to examine the linear relationship. That is the linear with the length between the medial epicondyle, lateral epicondyle, length between the olecranon and the medial epicondyle, length between the olecranon and the lateral epicondyle. These 3 lengths should be examined. This is not the isosceles angle. It's actually this is that the triangle is made that 3 arms are different. So this is most important. These 3 arms. So once you have to examine it, so then there is a longest arm is the interepicondyle line. Shortest arm is in between the tip of the olecranon and the medial epicondyle, and the intermediate arm is the tip of the epicondyle to the olecranon. This is the intermediate arm. So this is the way. So in supracondylar fracture, these 3 this linear relationship should be maintained. Only there's some complete tilting of maintaining the normal relationship. The whole triangle will be tilted medially. So that is the evidence of the medial tilt. Okay. Now, if there is some, this is most important part to diagnose. Differential diagnosis from the supracondylar fracture, from the lateral epicondyle fracture or lateral condyle fracture, supracondylar fracture from medial condyle fracture, and supracondylar fracture from the interarticular fracture. So if it is a lateral condyle fracture, the lateral arm will be increased, interepicondylar distance will be increased, but the medial arm will remain constant. It is the same as the normal side. If it is a medial condyle fracture, the medial arm will be increased, interepicondyle distance will be increased, but the lateral arm will become constant. But if it is a interepicondylar fracture, interarticular fracture rather, so in that case, what will happen? So in that case, there'll be all the three arms will be increased. Okay. Another important point is there's a dislocation. If there is a dislocation or the olecranon fracture, if there is an olecranon fracture, then fracture fragment is separated. So in that case, what will happen? Both the lateral arm and the medial arm will be increased, but the interepicondyle distance will remain constant. Whereas in the dislocation, what will happen? In dislocation, so actually the triangle will be reversed. So in that case, if we examine from the supine, from the front, so in that case, normally from the front, there is a triangle, apex will be upwards. That is, the olecranon will be upwards. But in case of olecranon fracture or the dislocation, then if you see from the front, the apex will be downwards. So that is the most important. Do you understand?
Yeah. The only issue here is that if you have a malunited, so in a fresh fracture, you're absolutely right.
Yes.
But once you have a malunion, then what you're feeling on the lateral side is not actually the lateral epicondyle.
Yes, yes, yes.
You have callus forming there and you're feeling that.
Yes, yes.
Okay. So if you actually measure the 3-point relationship with the 3 prominent points, you are actually not getting a isosceles or a equilateral or isosceles triangle.
Yes.
Okay? So I think one has to be aware of this. I know the teaching has always been that in a supracondylar fracture, these 3-point relationship is always the same. The problem is once you have callus formed, you're not actually feeling the lateral epicondyle. So you'll feel that the distance between the prominent point on the lateral side is more than between the olecranon and the lateral prominence is more than the olecranon to the medial epicondyle.
Yes, yes.
And so what about that stiff elbow and myositis ossificans? I think
Again, if it is a stiff elbow, it is a united elbow. Suppose there is some significant callus is occurring on the lateral side. So in that case, what should be the lateral epicondyle? That is why it is detected that is the downmost and outermost point, not the most prominent point. Yeah. So that is most important. So similarly, if it is a malunited lateral medial condylar fracture, so a severe callus is formed. So in that case, how to identify which one is the medial? That is why it is considered it is a downmost and medialmost point, innermost point. That is most important. Is it visible now? Is it?
Yeah.
Yes.
Okay. So now there is another swelling. As you can see, a swelling around the olecranon, and there is a traumatic swelling. As you can see here, this patient shows some blood is coming out. Now there are several scars where how to classify the scar. So this is the scar, as you can see here. This is a puckered scar, which is superficial and it is not deep. How do you know it is superficial or deep? We have to see the mobility of the scar in both the axes. Suppose it is scar is attached to the muscle. In that case, how do you identify whether it is a superficial scar or scar is attached to the muscle, or sometimes it is a healed sinus. Sinus is fixed to the bone. So how do you differentiate these three? This is most important. So you have to examine in this way. So you have to identify where is the scar in inspection, then palpation. We have to check the mobility of the scar at the right angle, both the axes. Suppose in the left side, this side, you have to check on this axis as also on this axis. So if it is mobile on both the axes, so most probably it is not fixed to the muscles. But if it is fixed to the muscles, then only in that case, if we mobile, it will be mobile at the right angle to the axis of the muscles, not in the same axis of the muscles. Again, if it is fixed to the muscles, you have to ask to contract the underlying muscles, that is the triceps. In that case, that mobility, that is right angle, that mobility will also become reduced initially. And when the muscle is relaxed, that mobility at right angle with the muscle will be there. But when the muscle will contract, that mobility will also become restricted. That indicates it is fixed to the muscle. But if it is fixed to the bone also, in that case, it is immobile in both the axes, irrespective of the contraction of the muscles. So in that case, if you try to move the scar away, so in that case, what will happen? If it is fixed to the bone, there will be increased puckering. Puckering will be increased. So that is these three clinical tests by which we can easily diagnose whether this scar is freely mobile, it is mobile in single axis, and that mobility is reduced by the muscle contraction, and if it is immobile in all the axes, irrespective of the muscle contraction. So this is the way. So this is a puckered scar, and this is a healed scar. That means there is some suppuration occurs. It may be traumatic or maybe surgical scar. If there is some scar marks, there is thread marks are there. And so this is the way we have to identify. Now, range of motion. So how to identify the range of motion? This is most important.
So elbow motion. So elbow motion can be examined like this manner. in this manner. Suppose we have to fix, we have to relax and see whether is how much extension is possible. How much is extension is possible from this? So this is the hyperextension method of hyperextension. And from that, ask the patient to flex it to touch the shoulder. Yes. So see, you can see from this side, you can easily compare the range of motion, whether it starts from the deformity or zero position, neutral position, and what is the range of motion. So this is the angle. Now see, from this side also you can examine like this. Yes. Examine like this. Now this is the starting, this is zero position, flex it, much more. Yes. So this is the range of motion. So this is the range of motion. Okay. Now the patient to hold the pain, or you have to hold it like this. This is the radial thyroid process. Now the patient.
Here it is one important point to be discussed. So during the examination of the forearm motions, we have to ask the patient to keep both the arms by the side of the body, so there will be no rotation. We have to obviate the rotation of the shoulder. That is one. Next one, we have to start from the mid prone position, that is the neutral position. I have to ask if you ask to hold the pin, we have to ask hold the pin in a very firm grip, very forceful grip. Otherwise, it will be very difficult. Other way, we have to check the position of the radial styloid to check the supination or pronation.
Like this. Yes. See? And you have to see the range of motion like this. This range of motion. This is the supination. And again, now yes. Compare.
And always check whether there is a deformity. So that means there is a movement is starting from the zero position or from deformed position. And then we have to check the arc, whether there is a hard stop or the soft stop, and it is associated with pain or not. If there's a terminal pain, it is diagnosed by the synovitis. If the whole arc is painful, that is the arthritis. Now the range of motion, we have to keep what is the actual range of motion, if we want to make the accurate range of motion. This is the most important tips for exact diagnosis, because sometimes in supracondylar fracture, some rotational abnormality, there appears to become, there is no flexion contraction, but this is the test, right? We have to keep the arm over the flat surface with the interepicondylar line parallel to the floor. This is most important. If we check that both the interepicondylar line is parallel to the floor, then only you have to check whether there is any flexion or extension is there, or extension deformity is there or not. This is the tips. Now again, see, this is the two condition is seen. There's a hyperextension. There's a hyperextension, but the flexion is same. And this is another case where we've shown that is the hyperextension, but there is some restriction of the flexion. So what is the case? So that hyperextension maybe it's a normal phenomenon. Normally in children, we have a 10-degree extension is possible, but sometimes it is more than that. But if there is some abnormal, there is excessive extension, there is hyperextension, but the range of motion is same. That means there is a possibility of some normal variants, or there is some posterior tilt. As you can see here, some mild posterior tilt. But see, if it is a significant posterior tilt and the proximal fragment is coming in front as a mechanical block, that will be the result. So that will be the result. Hyperextension, which is suggesting there is a persistent posterior tilt. That is why it is going much more hyperextended. But as the proximal fragment is going in front, making a mechanical block, that will lead to this sort of flexion restriction. So in this case, there is a hyperextension at the cost of restriction of the flexion. So that is the clinical test by which we can diagnose there is a persistent hyperextension element of the supracondylar fracture. Now the range of forearm motion, I already told the 2 points. We have to hold the object very firm. There's a forceful fist. Otherwise, it is a fallacious to check this the position of the pain. Otherwise, we have to observe the object or palpate the radial styloid. We have to keeping both the thumb on the radial styloid. We have to rotate either actively or passively to check the supination and pronation. Now, clinical detection of persistent component of the displaced supracondylar fracture is how to test the medial tilt, medial rotation, and the posterior. This is usually asked in the examination. So if we check in this manner, I'll show you. So in the next slide, the medial rotation is most important. Medial, if there is already there is some fragment is medially rotated, it is reflected to increase medial rotation of the shoulder at the cost of restricted external rotation. So that is the way you have to check in this way, you have to check the rotation of the shoulder. So in this case, there will be on the affected side, there will be increased medial rotation at the cost of restricted external rotation, so that the whole arc will remain same. So that is why you have to check both the rotation in this manner, and then that is the value of the examination of the rotation on the normal side also, because you have to identify the whole arc. On the affected side, the arc is same, internal rotation is more at the cost of restriction of the external. This I am highlighting this word repeatedly, because that is the way by which we can diagnose the excessive, indirectly diagnose the excessive medial rotation. And this is the way, this is the test. This is the basically is the Gerber's test. Basically, you can check the internal rotation of the shoulder in this way, as you can check the subscapularis. This is actually Gerber's test. We have to check. See, this is the internal rotation is much more. The limb is coming far away from the trunk on this side in respect to the normal side. So this is indicates this persistent medial rotational component of the supracondylar fracture. Now, this is the very important slide by which we can easily identify the persistent medial tilt and the dorsal tilt. As you can see here, the medial tilt I've already told. This is the way. So if you see from the front, there is a triangle. That is olecranon is at a lower level. There's an inverted triangle. And if we normal side, normally, if we draw an imaginary line, if we connect both the epicondyles in this manner and both the interepicondylar line in this manner, that will be parallel. But in this case, see, this is the epicondyle, this is the medial epicondyle, and this is the olecranon. If you draw it that line, this line is going up. That means there is a converging. Or in medially it is diverging, on the lateral side is that means this parallelism is broken. That is the way by which we can understand this medial epicondyle is going up. That means there is a medial tilt. There is a coronal tilt of the whole of the triangle, maintaining the linear relationship. This is most important. So this is identifying persistent medial tilt. It is asked, how do you know it is a persistent medial tilt? This is the answer. Okay. Now another important part is the dorsal tilt. As you can see, this is actually the radiograph of this same case. As you can see here, this anterior humeral line. If we draw the anterior humeral line, normally the whole the condylar component should cut at this line. But you see the whole of the condylar component going backwards posteriorly. That is the posterior tilt, and that is reflected by increased extension, hyperextension at the cost of restricted flexion. As you can see, that is acting as a mechanical block. So that is how the increased hyperextension at the cost of restricted flexion, that indicates there is persistent dorsal or posterior tilt. So it is asked in the examination, how do you know it is what are the components of the malunion is present in this case? There's a most important component is the medial tilt. Next one is the posterior or the dorsal tilt, and there is a medial rotation. Now, measurement of the arm length and the forearm length, as you can see here, I'm showing it.
Okay. Measurement of the elbow. The actual starboard point should be the angle of abdomen. How to identify the angle of abdomen? This is the spine of the scapula. We have to palpate like this. Spine of the thoracic goes right out, right which bends its character. So this is the angle. So this is the angle actually.
The angle is much more posterior point. So mind it.
This is the angle of abdomen.
And from the angle of abdomen is the lateral epicondyle.
Already identified the downmost and outermost point. This is the lateral epicondyle.
So this is the lateral, yes. This is the arm length.
So you have to measure it in this manner. You have to identify
And the forearm length.
So you have to go in this manner along the borders of the hand. So this is the radial standard process. This is the ulnar standard process, and radial standard process is 1.25 below the ulnar standard process. So this is the radial standard process. We have to examine the length of the forearm. Length of the forearm is measured. So this is from this This point to this point. So this is the length of the forearm.
Okay.
Now to
So this is the way to identify the arm length and the forearm length. Now the how to
now
the
to
carrying
measure the
angle.
carrying.
Now for the carrying angle, main prerequisite is the elbow should be completely extended. Should not be any degree of flexion deformity, and there be completely supinated. Elbow should be completely extended and supinated. This is the main the parameters to be fulfilled before the examination of the carrying angle. Now how to carrying angle?
The carrying angle. So basic prerequisite of carrying angle is there is lack of extension and lack of supination. Carrying angle cannot be prerequisites. Next one is the upper point of the carrying angle. So this is the auxiliary fold, and this is the maximum bulging point on the outer side. So this is the lateral point. You have to measure it in this manner.
So midpoint of these 2 points.
The middle point is like this. Similarly, this is the lateral epicondyle. This is the lateral epicondyle. And also, this is the medial epicondyle. You have to identify the middle point of the interepicondyle line. Suppose this is the 5 and 5 feet. So this should be the middle point.
Yes, we have to join this.
Extend it. You have to extend it like this.
Yes.
Now this is the interepicondyle line.
Interstyloid line.
After identify the interstyloid and the ulnar styloid. So this is the interepicondyle line, and this is the interstyloid line. Interstyloid line. So this is the angle. This is the angle. This is the angle between the.
Yes. So always we have to examine the medial normal side first and the abnormal side first, and depending on that, we have to check the deformity. If it's a cubitus varus, how much amount of cubitus varus is asked in the examination. So in the normal side, if suppose it is a 10 degree, in the affected side it is a 5 degree varus. So total deformity is 10 plus 5 equal to 15 degree. Now there is another important point is the posterolateral rotatory instability. So you have to check it. So this is the lateral ulnar collateral ligament is the main component of the lateral collateral ligament. It's 4 parts. I'm not going into detail. See the check. So lateral how to check the posterolateral instability. So you have to fix it. Fix the limb with the in between your arm and the chest, and you have to make the valgus and rotated stress over the axially loaded radius, while gradual extension to flexion that leads to dimple or the swelling in the region of the radial head. See, check this area. Check again. This is very important test. So rotated. So you have to fix it. We have to stabilize it. So make a valgus and the rotatory stress. Yes, valgus and the rotator. See, have to hold it. Have to fix it. Fix the arm. Do fix this? Yes, it is a valgus and rotatory stress is given from the flexion to extension to flexion, and to check this area. Yes, in this area, either it will be a dimple will come, or there is a swelling. That is a dimple, that means a subluxation. It is a swelling, that means it's completely dislocated. So that is a posterolateral rotatory Dwyer test. It is the most important Dwyer test. Another is a very important test is simple. That is ask the patient to raise his body from the floor. Patient will not be able to do that. So in that case, the posterolateral ligaments are torn. That will be very difficult. Now the varus and valgus test. The varus valgus test can be done in extension as also in 30-degree flexion. So in that case, in the same manner as you can see in your knee joint. So varus valgus test, if it is unstable in extension, that indicates it is either a bony problem or the capsular problem. But if it is unstable in 30-degree flexion, that indicates a ligamentous problem. Okay. The same thing. This is ask the patient to elevate the body from the chair with the help of the hand. The same thing you can do that. So this is the way by which you can easily. This is a dynamic step, a dynamic test. A patient is asked. A patient will be unable to elevate the body with the help of the hand resting on the handle of the chair. So that is the dynamic test part of the elbow. So now this is the case. So there's a diagnosis. Can anybody join in this? That may be the which sort of deformity it is. Can anybody join? So we can share.
Yes, Avinash,
Yes.
I think.
This
Yeah.
is the patient.
RDNB. Yeah. Yes, who is?
I can tell the patient profile. The chief compressive deformity at the left elbow for last 4 months. History of the patient illness is the fall on the outstretched hand 4 months back, treated indigenously, including the local massage. Deformity at the left elbow, there's insidious is onset with the forearm deviated inwards for last 3 months. It is a non-progressive. There is no history of fever, loss of weight. And see, all of the findings are normal in general examination. This is the clinical. So what is your diagnosis?
Sir, I have got one answer from Rajan. He
Yeah.
told cubitus varus.
Yes. Why it is cubitus varus? I've already answered. As the patient is standing in anatomical position or in this manner, so in that case, you can see here the forearm is deviated towards the center of the body in respect to the arm, once inspected from the front as also from the side. This is the one answer. Next answer is the carrying angle. The carrying angle is reduced or it is reversed. And what is the exact carrying angle? You can tell if it fulfills the criteria of the measurement of the carrying angle. So this is the two answers why it is a cubitus varus deformity. But the now question is, if there is some flexion deformity is also there is a varus deformity as also flexion deformity, then what will you tell? Is it now, can it be called as a cubitus varus deformity? Can anybody answer?
Anyone? Yeah. If they have listened the lecture carefully, they can answer, because you already told in the beginning. Yes, Rajan? Yes or no?
Can it be called as a cubitus varus? Because there is a both. There is a varus deformity as also flexion deformity. That is flexion. Cannot be fully extended. So in that case,
sir, we don't call it cubitus varus deformity if it is not in fully extended.
Exactly. So in that case, what should be your answer? What you tell in your exam? Then you have to tell you can tell it is a Gunstock deformity, or it is a biplanar deformity, or you can tell it is a stiffness of the elbow with deformity. Stiffness means as it is a flexion contracture, that is a flexion deformity. That means the elbow cannot be fully extended. That means it is a flexion deformity. Okay. So in that case, you can tell it is a case of stiff elbow with biplanar deformity. You can tell it. Otherwise, you can tell it is a Gunstock deformity. So then the examiner of what is Gunstock deformity, why you are telling not it is a cubitus varus, then you can give this, sir, it has a biplanar deformity, both in sagittal and the coronal plane, as also there is some restriction of flexion. So this is the answer. Now, again, inspection from the front, I'm not going to detail. It is already, everything is discussed. Now, can anybody tell from the inspection, is there any other deformity apart from the cubitus varus is visible? Apart from cubitus varus, any deformity is visible or not? Any?
Sir,
yes.
Yes, Sachin.
sir, the shoulder may externally rotated more left side.
See, the external rotation or internal rotation depending on your the palm. This palm is this is a normal anatomical position. Palm is completely facing forward. So in that case, you cannot mention it is a internal rotation external, but some other obvious deformity is visible in this case. See the length
of the
arm, length of the arm. Okay. Now, usually it is asked, what is your diagnosis? You can tell it is a case of cubitus varus deformity of 4 months duration following a malunited supracondylar fracture. Now, next question, what are the first question? What are you calling is a cubitus varus? Next question is, what are you telling it is a supracondylar fracture? And next question will be, what are you telling is a malunited supracondylar fracture? Okay. Now, what are the points in favor of supracondylar fracture? Most important one of the most important point is the thickening of the supracondylar ridge, maintaining of the relationship of the 3 bony points, the shortening of the arm, and the forearm length is maintained. So even the shortening, so if you got the clue from the inspection that it is now your answer will be very easy. That may be a case of malunited supracondylar fracture. As you can see here, the level of the elbow, it is almost towards up to here, but here the level is a little bit higher, so it is definitely shortened. Now, suppose C, it is looking like this. Yeah, you can inspection. Keep it your mind open. Can it be the cubitus varus, or it may be the cubitus varus with some flexion deformity, isn't it? You can see here, patient. If you see from the side, there's a flexion. How to solve it? So there's some dilemma. Can you tell if the cubitus varus or not? Now this is the way. Now ask the patient to keep the limb in this manner. Now the gravity will help you to give the answer. Now we can see that there is no flexion deformity. It is almost zero, isn't it? So
Yes,
now
sir.
it is zero almost. So there is no flexion deformity. It is basically there is a normal extension is there on the other side. Here the extension is lost, but there is no flexion deformity. So this is the tricks by which we can easily understand. And the examiner may also ask you whether it is a pure cubitus varus or not. Then this is the answer. So you have to check it in this way. Okay. Now inspection from the back is very important. I've already told, I'm not going to detail. And this is the way, so that's by which you can easily understand this imaginary line joining the both the epicondyle. And you can see here, this line, this is a line. You can see here, this line is not parallel. This is going up. This is the medial epicondyle. It is not parallel with each other. See, this line is parallel with this line, but this is going up. So this is the test by which you can understand there is a persistent medial disease. See, the whole of the triangle is rotated in the coronal plane. Okay. Now temperature I'm not going to detail. And so what are the areas we have to check the temperature apart from this front? That is the anconeus triangle. Okay. So now palpation method I've already told. I'm not going to detail. Relative position of the three epicondyles. It is discussed. The range of motion is already discussed. This is the very important way I'm just highlighting. See, in this case, it is apparently there is no flexion deformity. But in this case, I can see here, the epicondyle is going a little bit higher up. It is not touching the table. So that means the inter-epicondylar line is not parallel. So if we have to very much keep it in your mind. So once you have checked the flexion extension, especially in case of supracondylar fracture, as there is some rotational component is already there, so you have to check the flexion extension, keeping the inter-epicondylar line parallel to the table. This is most important. Okay. Now the supination pressure is already discussed. Carrying angle is already discussed. The measurements, it is already discussed. And see this case, this is the very important. So see, this is the normal side. This is the abnormal side. The inter-epicondylar distance is 7 centimeter. Medial arm is 6 centimeter. Sorry, the lateral arm, it is a 6 centimeter. This is the lateral arm is 6 centimeter. See the medial arm. Medial arm is 4 centimeter. Here is the medial arm is 6 centimeter. Medial arm is shortened. As the lateral arm is 6 centimeter. It may be more. So what is the explanation? What is the explanation? Can anybody tell it? What is the fault?
Yeah, I think is
Where is the
active.
problem? What is the problem?
Yeah. Sachin.
Why is the problem? Problem is that we have to identify the downmost and outermost bony point along the lateral supracondylar ridge or the medial.
One answer we got, sir, medial tilt from Subhansu.
Yes. See, actually, the downmost innermost bony point over here it is examined much away. It is should be over here, so that will actually maintain. That will be actually ideal. Okay, so that is the common fallacy. It is made in the examination. We have to identify the medial epicondyle, which is the downmost point. It's not the most prominent point. Okay. Next is, I think it is a different way. So diagnosis should be the cubitus varus deformity of 4 months duration, probably due to malunited supracondylar fracture of the left non-dominant side with restricted elbow flexion, may or may not be, with limb length discrimination, may or may not be, without distal neurovascular deficit in a 12 years old male patient. So that should be the complete diagnosis. Okay. So is there any questions? We can, I love to answer it.
Yes, sure, sir. Sure, sir. So, as in the diagnosis, you have mentioned about the dominance. So, the handedness, we need to ask, I think.
Yes. That has to be mentioned it. Now, next question is, I'm just telling the questions it is asked in normal examination. Now, why we're telling is the cubitus varus, why we're telling it is a supracondylar fracture, why we're telling it is a malunited supracondylar fracture. What are the components of the malunion present in this case? Okay. Now, how do you draw the carrying angle? Show the methods of epicondyles detection. How do methods of arm length, forearm length? How do method of carrying angle measurement? What is the actual deformity? How to quantify the deformity? Okay, so these are the normal questions usually asked. What are the differential diagnoses? Again, I'm already discussed what are the differential diagnoses. That means it may be the lateral condyle fracture, it may be the medial condyle fracture, it may be olecranon fracture, it may be dislocation, or it may be fracture dislocation, or it may be malunited olecranon fracture. So these are the all differential diagnoses you have to keep in your mind. Now, next, how to confirm your diagnosis? Yes, please. Any questions?
Yes, sir. We have one question in the chat box by Arnendu. He's asked to repeat about how to check medial and lateral tilt.
Yes.
Maybe.
Normally, what happens in the supracondylar fracture, there is a medial tilt. That means the whole of the triangle is rotated like this, isn't it? It's rotated in this manner. Whole of the triangle is rotated medially. So if it is rotated medially, normally what happens? Normally both the condyles, it is in a same line. But if it is rotated like this, if you draw if you keep your both the elbows in front of him, if we examine from the front, so in that case, if you imagine a line joining both the olecranon and if you see the medial condyle will be little bit higher up. That is on relative position of the medial condyle in comparison with the other side. That is the one. So if somebody asks where it is given, actually it is described by Shammukha Sundaram, and it is in some books it is described. It is Shammukha Sundaram's test. That is one. Second one is the whole triangle is rotated. So if we draw the triangles, keeping the linear relationship maintained, whole of the triangle is rotated. So in that case, this interepicondyle line is either convergent or divergent in comparison with the trans-olecranon line. So that is the second point. So in this way, we have to identify the medial epicondyle is completely rotated in keeping the linear relationship of the three bony points. This is the most important. So that is how we can tell it is a medial tilt. In supracondylar fracture, commonly medial tilt happens. There is no lateral tilt occurs. Okay. So this is the way medial tilt. Now posterior tilt. Posteriorly, that the fragment is going posteriorly. So what happens? There is a hyperextension. So at the cost of restricted flexion. Okay. So sometimes the extension is not there, but there is restricted flexion. So what is that? What is the diagnosis? If hyperextension is not there, if there is hyperextension and the amount of hyperextension is exactly that amount of restricted flexion, that is the posterior tilt. Okay. But if there is no hyperextension, but there is a restriction of flexion, so what is the cause? There are several causes. It may be callus formation causing the mechanical block. It may be myositis ossificans. It may be some displacement. But the posterior tilt is not there, but there is some anterior posterior displacement from the fragment. So these are the differential diagnosis. Okay. Again, myositis ossificans. This is also another important differential diagnosis. So in that case, how do I diagnose the myositis ossificans? There is some history of massage, or there is an inadvertent movement. Even without the massage, inadvertent mobilization and the movement can cause this myositis mass. So in that case, we have to palpate in front of the elbow. There is some abnormal bony hard swelling. And in that case, there will be restricted flexion only. There will be no hyperextension. Okay, these are the point we can easily identify. One question is, I think,
in the gunstock deformity, there is some click during flexion. What is that? As with Subhansu.
Click inflection, I don't understand what does he mean to say. Click
maybe block is, yes, maybe asking about the block. Yes.
Yeah. That is I've already discussed. So if there's a flexion block, what are the differential diagnoses? It may be excessive callus formation. It may be myositis ossificans. There is a displacement of the fragments in front that leads to the block, or there is hyperextension with reflection that leads to the persistent posterior dislocation, posterior tilt.
I think he probably means a sound or something when you're doing it.
Yes, that's
Yeah.
if it is sound, yes. If there is a, we have to, I already told that we have to check if there's a flexion block. It may be it's a hard stop or it may be a soft stop. If it is a hard stop, that means it is a bony block. If it is a soft stop, that may be due to some soft tissue contracture. It may be either a capsular contracture or it may be some other contracture in front of the ligamentous contracture. So it is a soft block or the hard block. I think.
And by and large, these sounds, clicks, etc., as long as they're not causing symptoms, are not usually of any significance. Okay, because in the knee you'll get it, in the elbow you'll get it in some people, even in normal children. The other thing is to try and avoid using the term myositis ossificans and rather use heterotopic ossification. Okay,
Absolutely, absolutely. It is a misnomer. It's a misnomer.
So one thing actually we want to know for the postgraduate, if there is tennis elbow or golfer elbow, which is we commonly seen in our OPD, that may be a case for examinations.
Yes, that is a very good question. We have opened the Pandora's box actually. So sometimes in our clinical practice, once there's some pain on the outer aspect of the elbow, so we have already diagnosed. Sometimes the patient tells, "Sir, hamara to elbow to nahi hua." Wahi baat hai. So how to identify it? So actually, tennis elbow is like basically it is a lateral epicondylitis or epicondylosis. So what is that? Basically, it is a degeneration of in the region of the origin of the extensor carpet radialis brevis muscles that leads to inflammation. Okay, so initially degeneration, there are several causes. There is no consistent causes. That may be due to some forceful action like the tennis players, the backhand stroke players, that can be true. But now how to identify it? So basically, there will be tenderness on the outer aspect of the elbow, especially on the lateral epicondyle or around the lateral epicondyle. But usually the tenderness will be above the level of the radiocapitellar joint, above the level. This is most important. If the pain is below the radiocapitellar joint, that is not the case of the tennis elbow. That means some other causes like the supinated tunnel syndrome. Supinated tunnel syndrome. So basically that happens because of there is the arcade of Frost is basically it is a process. It is a structure, the fibrous structures in the substance of the supinated muscles. So once the nerve of that is the posterior interosseous nerve is coming in between the two heads of the supinator and it is trapped in between the arcade of Frost, and that leads to pain. So usually it is a dictum if the pain is above the radiocapitellar joint. It is maybe a case of tennis elbow that has to be confirmed by some special test. And if it is below the level of the radiocapitellar joint, that may be a case of radial tunnel syndrome, or that is to be tested by the confirmed by the special test. Now come to the special test. Now, if it is the tennis elbow, see if you ask the patient to dorsiflex the wrist in this manner, patient will complain of pain on that elbow. That is the one. Second, there are some, that is the Cosen's test. Cosen's test is we have to ask the patient to extend the elbow, and we have to ask the patient to dorsiflex against the resistance. So this is the way. There are several other ways that means the dorsiflexion against resistance, keeping the elbow extended, keeping the elbow flexed. That is the way but we can, if there's a pain is complained of, that is the Cosen's test positive, and that is due to tennis elbow. Now, if it is the radial tunnel syndrome, in that case, that is nerve is trapped in between the supinator. We have to ask the patient to supinate against resistance. When the patient is the supinator muscle is contracting, that will cause severe pain on that area. That's just in the upper part. So that is the diagnostic test of the radial tunnel syndrome. Now the golfer's elbow is just that's counterpart of the tennis elbow, that is complaining of pain on the medial aspect. That is on the medial aspect of the elbow. And in that case, if you ask the patient to palmar flex the wrist, so in that case, patient will complain of pain. Again, if the patient is complaining of palmar flexion against resistance, patient will complain of this is the provocative test. So this is the golfer's elbow and another important point is that is the pronated teres syndrome. Sometimes the golfer elbow, sometimes it is confused with the pronated teres syndrome because the median nerve is coming, that one side has become the anterior interosseous nerve. That nerve enters inside the forearm in between the two heads of the pronated teres. So that leads to pain around the upper part of the forearm, that is almost similar to the golfer's elbow. So in that, how do you identify? Again, you have to ask the pronate. I'll ask the patient to pronate pronate the forearm against resistance. Now the pronation is done by the pronator teres and the pronator quadratus. How to isolate this? This is also important. How to isolate the pronator teres from the pronator quadratus? Now pronator teres is not only pronator of the forearm, but also it acts as a flexure of the elbow. Flexure of the elbow. Okay. So if we pronate again, keeping the elbow extended, that is the function of the pronator quadratus. Okay. But if you ask the patient to flex the elbow as also pronate it, that means that is a function of the pronator teres. So that is how we can easily add. So resistance against the pronation, keeping the elbow flexed, that is the test for the anterior interosseous nerve compression, is the pronator teres syndrome. Okay.
So just one last question, sir. During the examination, sir, do you also notice or put some marks for if the greeting to the patient or like thanking after the doing the examination, or you notice it or not? For after the examination, sir, by the examinee, if he examined the patient or greet from the beginning or explaining the procedure before that, and after completion, if he thanks, do you notice these things also, sir, and
Yes,
keep some marks for that one?
Thank you for this comment. I'm just it is the basic prerequisites. It is the basic prerequisites. I'm highlighting this point as you have highlighted. Basically, in the Western countries, the patients are actually the examiners of the student. Patients are basically how they behave with the patient, how they deal with the patient, how they make them understand. This also carries some marks. So actually, in our country, we are very fortunate that this sort of examination is not included in our examination system. But we have to become very much respectful to our patient. So in that is the basic prerequisites is we have to take the permission of the patient before touching it, that patient. This is very extremely important. You have to keep them comfortable. If the patient feels uncomfortable, that is a discredit of the student, and that carries a bad impression by the examiner also. So always take the permission of the patient. We have to become very much respectful to the patients during this undressing and everything. We have to explain everything what to be done for this patient, and then we have to touch the patient. This is extremely important and basic things. We have to keep it in mind. Every patient should be kept it in mind.
Just one last question comes from Dr. Ardhendu Pandit. Is certain examination, if we ask to check posterior instability of the elbow, we should examine both in extension and flexion, or have to check by any one method?
No. Posterior instability means what? Posterior, there is a posterior subluxation. Okay. So this is a simple way. Especially it is important during the operative examination. In the clinical, it is not significantly, it is possible. But again, you can check it. But if you ask the patient to extend the limb in this manner, and against the gravity, and they will sag, that the whole of the limb will sag, and patient will feel uncomfortable like this. So this is the way, but we can easily understand there is some posterior subluxation is going on. Okay. So ask the patient to extend the limb, and in this against the gravity like this, you have to hold it. So if there's a posterior subluxation is going on. So in that case, patient will feel very uncomfortable and immediately will flex it. So to prevent that. So it is like apprehension. So this is the way we have to check whether there is it is especially seen in case of coronoid process fracture. Suppose it's a coronoid process fracture. This is a small fracture. It is 3 to 4 weeks already passed, but it is not healed at all. So in that case, after initial 3 to 4 weeks of immobilization, we have to check this, whether there is this instability is present or not. If the instability is still present, there is the indication of surgical fixation. Okay.
So there's a couple of tests for this. What has now become fairly common is this posterolateral rotatory instability of the elbow. So when you do that, you also give a valgus stress. The second is the chair test, where you ask the person to lift himself up from a chair, and then he'll have pain. And sometimes you can actually hear a click during the movement. So all these things you need to keep in mind. And this is not a very common case, so the chances of you actually getting it in the exam are not very high. But if it's there, they might keep it. Okay.
Thank you very much, sir.
Okay. Thank you, Dr. Pal. That was very useful, and I think did elicit a lot of questions from the delegates. So until next week, bye to everybody, and have a great week. Thank you.
Thank you
Thank
so
you.
much, sir.
Thank you.
Bye.
And
Thank
I think we will go on. There is a common mistakes in common cases, and
Yes.
we
Sure.
will continue for our beloved students.
Sure.
Yes.
Okay.
Thank you so much.
Thank you.
Bye.
Bye.